Thank you very much. My name is Connie Hill. I am a psychiatric mental health nurse practitioner student at the University of Texas, Rio Grande Valley. This is my evidence-based presentation to complete the requirements for Nursing 6260-90L. This is summer, session 1, 2018. My evidence-based topic was to determine if bright light therapy could be used successfully as an adjunctive therapy to pharmacotherapies for depression. To support and look at the evidence for the need of bright light therapy, I looked at the National Institute for Mental Health, who indicates that 16.2 million Americans suffer from at least one episode of major depression in 2016. And of these individuals, 10.3 million had a major depressive episode with severe impairment. Treatment patterns for these individuals included 44% were seen by health professionals and received a medication, 6% received medication only, 13% only saw the healthcare provider, and 37% had no treatment. So if you look at the individuals from the 6%, 13%, and the 37%, we have to wonder, was psychotherapy considered? Was medication considered in the last two categories? And would bright light therapy have been an option for these patients if it was accessible and supported by the evidence? Particularly, I wanted to look at bright light therapy as used in perhaps rural areas. The problem is in rural areas, which is where I practice, we have very limited access to qualified mental health providers. And most of the mental health care there is provided by either family practice nurse practitioners, adult gerontological nurse practitioners, and or primary care physicians. And often the only treatment offered for depression is pharmacotherapy. The patient's financial resources may act as a barrier to psychotherapy. Bright light therapy could be an affordable and easily accessible adjunctive therapy for the treatment of depression if supported by the evidence. So the purpose of my paper was to determine the evidence to support the bright light therapy as an adjunctive therapy for depression. And to first get started, I looked at the background for bright light therapy and found that it has been documented in the literature to be used and recommended for seasonal affective disorder, depression. But it's rarely written as a recommendation by mental health providers. So we failed to actually synthesize this into practice. It is rarely seen as a possible adjunct recommendation for major depressive disorder or for bipolar disorder. Rural areas often do not have access to mental health providers trained in cognitive therapy. Patients and referring providers in rural areas may have excessive wait times for their patients to see a mental health provider if they can even get into one. So the addition of bright light therapy to providers would actually provide them something else in their toolkit to perhaps increase compliance for the patient, perhaps also to have the patient participate more readily and provide improved quality of care in the community where it's being offered by the provider. I started first by looking at the literature from 2013 to present. I did look in these databases. I used the terms depression, light therapy, bright light therapy, and any mental illness. Omitted any study protocols, and I will say that there are a number of study protocols being done on bright light therapy right now across varying types of depressions. So I looked at 6 articles in the literature domains of seasonal affective disorder, major depressive disorder, and bipolar depression. From the literature review, I found these major themes. Screening for depression and compliance to the recommendations is very, very important to the patient's outcome. Coexisting medical illnesses complicate depression management, and I think the ability to add something like bright light therapy could really enhance outcomes for remission. Mental health providers should consider novel approaches, one of these being bright light therapy. And that bright light therapy is safe, and it's safe to add it to pharmacotherapies, and psychotherapy was a major thing. There was mentioned in several studies that there's insufficient evidence at this point to determine if there really is any difference in the effect of bright light therapy between ethnicity groups or gender. So first I want to talk about bright light therapy in seasonal affective disorder. And I looked at a randomized clinical trial by Jervlin et al., and you can see the references there below. It specifically investigated the effect of bright light therapy that was administered in the ear canal. And this study had 3 groups of individuals who were administered varying doses of light therapy, low, intermediate, and high. And the patients were measured before, during, and after with the Beck Depression Inventory, with the trail making test, and if you're not familiar with that, that's a neuropsychological test of visual attention and task switching. Then also the Hamilton Depression Rating Seasonal Affective Disorder Scale was used, as well as the Hamilton Anxiety Rating Scale. So the mean decrease in the Beck Depression Scale was 66% or 12.9 points. The SAD scores decreased on average by 46%, and that's with a p-value of 0.0001 across all 3 groups. This was noted. And the Hamilton Anxiety Rating Scale score decreased 40% across all 3 groups. So all 3 groups saw marked improvement. Of note is that one thing about this study was it did not have a control group. All 3 groups were treatment groups. They were just at varying degrees. And then I looked at a retrospective design also for seasonal affective disorder that looked at the difference in response to bright light therapy between the 2 groups that received it for different periods of time. Again, the SAD and the Hamilton Anxiety Rating Scales were used to measure the response before and after therapy, and both groups showed an exceptional and progressive decline in their depression scores from day 1 through day 15. There was a 3rd study that was looked at for seasonal affective disorder, and that one I specifically looked at for the purpose of looking at gender and ethnicity, and there just really wasn't enough data to provide sufficient information to demonstrate a difference. So the groups were large enough, but it did not show a difference between the groups. And it was really one of the only studies I could find about ethnicity and gender. So, of course, that will be one of the recommendations, is that more studies need to be done to determine if there is a difference in how bright light therapy affects individuals with these different categories of depression based on ethnicity and gender. And next we looked at bright light therapy in major depressive disorder, and this was a study by Lamb et al. This was an 8-week trial of 122 adults, and it was conducted to determine if bright light therapy in combination with fluoxetine improved depression scores. All of the participants had the Hamilton Depression Score. done prior to it, and they were not considered for participation if their depression score was not 20 or greater. So they were randomized to one of 4 groups, and you can see here that group 1 received the actual bright light therapy but a placebo orally. Group 2 received bright light therapy, but it was actually a placebo bright light therapy. The sound was there, the light was there, but there was no emission of ions, and they received fluoxetine. So in group 2, they actually received, the only real treatment was fluoxetine. In group 3, they received the actual bright light therapy, and they received fluoxetine. Again, 2 treatments were given in that group. And in group 4, they received the bright light therapy, which was a placebo because there was no ions admitted, and the oral medication was a placebo. So in this study, all participants, as we said, had to start off with a score of 20 or greater. And what we found that was in all cases, the bright light therapy with the combination of the oral therapy was superior. The mean change in the MADRS score, which is the Montgomery-Åsberg scale, it is a 10-item diagnostic questionnaire used to measure the severity of depression, and the mean change in that score from baseline to the 8-week point went from 16.9 to 9.2 for those receiving combination therapy. It went from 13.4 to 7.5 for those who received light therapy only. So it was marked improvement between those who received the combination, and the p-value on that was less than 0.001. Then we looked at bright light therapy in bipolar depression, and there's been literature to support that circadian rhythm and sleep-wake cycles of individuals with bipolar depression can be significant. So given these results, the researchers sought to gradually increase the exposure of the duration to bright light therapy so as not to cause any conversion among the patients to mania or hypomania. And they wanted to adjust the exposure of the time of day to midday so that there would not be any influence of either bright light in the morning or full night in the evening. This was a 6-week randomized, double-blinded, placebo-controlled trial. 63 patients were consented, but 46 participated. The patients were ages 18 to 75. They all had the diagnosis of bipolar 1 or bipolar 2, and they were on stable doses of bipolar medication. They were randomized 1-to-1 to either the 7,000 lux bright light white box or to the 50 lux red unit, and that was the control group. They started off with 15-minute light sessions between 12 noon and 2:30 each day, and the participants and the study personnel were blinded to the treatment box issued to the patient. The patients all went to weekly visits where they brought their box, and they were assessed for mood, side effects, suicidal ideation, sleep patterns, and quality and psychosocial functioning. The light prescription was increased by 15 minutes after each visit, with the goal being to obtain 60 minutes per daily treatment by week 4 or until remission was obtained. The principal investigator and the non-blinded monitor examined those patients who were not able to have their light therapy advanced because they were symptomatic. And if it was required, the clinical management was initiated in these participants. So symptoms at baseline with each visit were assessed as just stated, and they did use the Hamilton Depression Score, the Atypical Depression Supplement, and the Mania Rating Scale, as well as the Pittsburgh Sleep Quality Index. So remission in this study was defined by having the SIAD score of 8 or less. The majority of these patients were enrolled in the fall and in the winter. And the results of the study showed that patients in the treatment group had a higher remission rate, 68.2%, compared to the control group at 22.2%. The treatment group experienced lower depression scores, 9.2, at the endpoint visit when compared to the control group, who had a depression score of 14.9. The quality of sleep improved in each group, and no improvement was seen in the control group until about day 4.33, which is significant because we need to know at what point can we expect to see improvement. So this tells us that providers can safely use and add bright light therapy as an adjunctive therapy for the treatment of various types of depression. Specifically, in this review, we looked at seasonal affective disorder, we looked at major depressive disorder, and we looked at bipolar type 1 and type 2 disorder. We did not see any significant difference between gender and ethnicity among these studies, although additional information is needed in that area through continued research. There was one pregnant patient in the bipolar 1 and bipolar 2 group. There was no significant difference noted, but again, there's not enough evidence to say that it can be used in pregnancy. So the future implications are that this provides an additional tool for mental health providers. We need additional research to validate the findings to date and to make sure that it is reliable when used again in our practice. Research in other areas of mental disorders where depression plays a role are needed as well, so that the results can be generalized. Studies that use mental health providers, MADRS, the Montgomery-Åsberg Depression Scale, along with the participants scored Montgomery-Åsberg Depression Scale, is important to verify improved quality of life. The bright light therapy needs to be further researched among different gender and ethnic groups. Thank you very much. I enjoyed this project and hope that it will be helpful to others in their day-to-day mental health practice. Thank you.